Hello, hello, and this is Jonathan Munoz again for the second delivery of these Find Your Angle videos. And so let's start. Today we're going to talk about palliative care and how could this be your angle. And this is a very important one, guys, because a lot of international medical graduates that come to the United States don't know much about the importance of the end of life conversations and palliative care, which involves hospice care too. So let's give a couple of definitions. Palliative care means um, any measures, any treatments that you can do to palliate symptoms, palliate the disease process without necessarily intervening in trying to stop or trying to enhance or fasten the disease process. Hospice care is part of palliative care, and they are always going to ask you this. Hospice care is part of palliative care, as when the family said, well, we don't want to continue more treatments, not even palliative care. We want to focus on comfort care. We want to focus on my loved one to be at home, to be free of pain, to be without symptoms. And if he happens to deteriorate and pass while at home, well, he will be with family and he will be a happy person for the time that he has left. That kind of is hospice care, involves a team of doctors, nurses, social workers that take care of this patient at home or at a facility many times, or even inside the hospital, which is called the inpatient hospice care. In many places known as GIP. So that is hospice. Hospice care is given by a team, doctors, nurses, social workers, chaplains. Can be at home, can be at a nursing home, can be at a group home, can be in the hospital. And the end of life conversation is the conversation that is an art, like kind of, to have this conversation with family members to make them understand why is this patient dying, and with this conversation to explain what are the options of treatment. At the same time, understanding what are the goals that the patient has, what are the goals that the family has in case the patient is not able to bring up his own wishes for because of dementia, because of non-verbal status, comatose status. Um, that conversation, which is not easy, is the center of this video. This conversation. Okay, let's start with this. This conversation, the end of life conversation, is what I want you to try to understand, so it will be your angle. Okay, so this conversation is, you talk to a family. So let's say you finish your workout, patient is very demented and continues to aspirate. Now you talk to the family and say, well, your mom is 99 years old and she's very frail, very cachectic. She's aspirating continuously, and one option is to start a YouTube placement so we can feed her through that and try to avoid further aspiration. The other option is, well, we don't do anything and we give her as much food as per mouth as she can tolerate without having significant aspiration, just for comfort, just to keep her mouth hydrated. But we know that because of this reduced intake or maybe no intake, she will continue to weaken, and at some point she will sleep more, and because she's sleeping more, she won't be eating anything and she will pass. But we will ensure with the hospice team at home that she will pass in a peaceful way, and that's your explanation. You're explaining the severity of the disease. You're explaining the why you think this patient it's getting to this point, maybe dementia, maybe something else, and you're explaining the alternatives of treatment. Now, while you do these three steps, if you show empathy, if you show respect, if you show real interest on helping them find what suits best for this person, this family member, based on their beliefs, based on their religion, based on whatever they believe on, you help them find that, they they will choose either one or the other one, but they will create a relationship with you. And this is what is very difficult to find in international graduates, because on their first year, they don't have any idea of what is hospice care, comfort care, hospice. They are learning it. But it's in the first year where we evaluate you to say, you're going to termination, you're going to probation. And I'm trying to give you a grasp on this aspect, so you can use this angle on your rotations and observations to impress. You can use it on your personal statement to impress, and you can use it on your interview to get your attending in your pockets. So how could, now the thing is, guys, if you do an observership here, by law, you're not supposed to talk to a patient or to a family member and explain them this. You're not supposed to do that, because this is a very deep conversation. This is a very important conversation. But if you're in your country, if you are working in a hospital or you're volunteering at a hospital in your country, keep working with all patients you have. And if you're in an area that has a variety of patients, you will come across a patient that has a family that is dealing with the end of life. And I want you to go there, get involved in the case, learn as much as you can about the case, and participate on the discussions with the team, and maybe learn if palliative care or hospice care is something that's going on in your country, and if it is, how it's approached, and what is the importance of the treating doctor on making this recommendation in a way that is sensitive to the patients, in a way that is coming from a place of real interest on helping them, on alleviating suffering. So in your country, find those patients, study them, help them, establish relationships with the family members. And if you can explain, sometimes, and this is the situation that happens in the United States, family members don't understand really the severity of one disease. They don't understand why dementia is causing aspiration, and why is this patient prognosis is very poor. They don't understand that. So that's when you explain and learn how to explain this. Learn how to explain the severity of the disease that their loved one is going through. Maybe by explaining the laboratory results, the x-rays, maybe by explaining your patient has a lactic acid of 8, which is usually a marker of severe infectious process. And his blood pressure is trending down, which also tells us that he is in shock. These are not good findings. These are findings that say she is losing the battle. And at this point, we have to decide if we keep going with aggressive treatment, or we decide to maybe pursue a more conservative approach. And while you learn to have this conversation, while you learn to provide this information, this insight, this and getting to know what they wish, it will come a time that they will tell you, Dr. Munoz, I hear what you're saying, and I think my father, he would have wished that we don't intubate him, that we don't resuscitate him. He would wish to be able to pass in peace. So could you help us? And I said, sure. I think that this aligns with hospice care, hospice philosophy. Let's start comfort measures. Comfort measures are any treatment that is directed to only treat symptoms. So you get that decision, and then you communicate to your attendings and say, this patient is now going into comfort care. We're going to stop antibiotics. We're going to stop vasopressors. We're going to wean him off oxygen and extubate him, and we will allow him to pass. Or we're going to send him home with a good amount of pain medications, a good amount of anti-anxiety medications, set a visiting doctor. He's going to go home on hospice, and it's expected that he passes, but he will pass at home. So you make that decision. If you learn this in your country, you will know the steps. And when you come here, when you create, when you go to an observership, and the residents or the doctors that you're following start discussing very complicated patients that have advanced CHF, advanced COPD, advanced CAD, and they are coming many times to the ER, to the hospital to be hospitalized, and you think, I think this patient should be evaluated by the palliative care team and try to figure out what are their goals of care, and it may help us to understand what are they going through. And many times when I see this in medical students, following my recommendations on rotations, and they tell their attendings, hey, I think this patient should be visited by the palliative care team. Many times we find that a patient that is currently on full code, meaning that they want resuscitation and they want intubation if needed, many patients that are in paper in full code, once you have a conversation of clarifying goals of care, they say, I wish, I want to be DNR, I want to be DNI, I don't want any of this. I want to go home, and I understand that I will die, but send me home. And that is hospice care. Many patients will tell you they want to be DNR, DNI, or they want to go on comfort measures. And the family will agree because it's their loved one decision. And with that, many students have achieved good, a good qualification on the rotations, because doing or having such conversation, or even thinking about, aside what is normal medicine, aside of what is the treatment for a patient, thinking about, hey, this might be an alternative, this hospice care, this comfort measures, this is an alternative, and we don't know because we haven't asked. So if you bring up that in your observership, saying, Dr. Munoz, your patient is very old, your patient has all these problems, and he has been here many times. Do you think it's time to call palliative care team and clarify goals of care? Or what about discussing hospice care at this point? And I will be like, I didn't think about that because I have too many patients, but you're a student, so you have more time than me to think about this. So thank you. So then you impress on your observership rotation. Now, how would you use this on your personal statement? And this is something very important, because now that we're saying that the personal statement should have a story, not just you saying, I am very smart and I am very happy and hardworking. You should start with a story. Even if you don't start chronologically saying how you started into medicine, how you went to medical school and all that, you could just start with a story, mentioning my interest from medicine comes from my love to help others. During medical school, many times I volunteer in the internal medicine ward, and I believe that having deep conversations that go into identifying goals of care in every patient, understanding their thinking, understanding their ideas, help us to make sure that we're following the appropriate treatment, which many times is not just based on medications, but can be also based on avoiding symptoms during the end of life, as accepting the end of life and helping them transition to this stage, through this stage, with dignity and with love. And in my last year in medical school, I had the opportunity to guide a family that didn't understand well what was going on with their loved one. And once we were able to understand that this intracerebral hemorrhage has caused severe non-reversible brain damage to the point of brain death, we were able to figure out that the family and the patient wanted to go to comfort measures, and inpatient hospice was initiated with terminal extubation. The family was present through the whole process, and they were at peace. They were overall satisfied and happy to allow their loved one to rest. And I feel very grateful that I was part of this process. So you tell this story in your personal statement, I think that I will feel very reassured of your knowledge, because not only you're understanding the medical process that's causing this patient's death, but you also understand the alternatives of treatment that you can provide to a patient. And you're able to have this conversation, and you're able to bring this patient to make this decision, or this family to achieve this decision, which is not easy, guys. You will see it's not easy, and you think about this and you keep this in your mind, so it's a good thing. So now we have how you're going to use it on your observerships, on your personal statement, and during the interview, you just talk about it. Once you learn about this hospice care, palliative care, end of life, once you learn about this, once you have your interview and they ask you, so are you interested on palliative care? It's a great answer if you can really deep dive into explaining why you want to be into in medicine, and you like to have these deep conversations, and you like to explore many alternatives of treatment. You're not just focused or close on one. So hopefully this was easy to understand. It's not a very easy topic to discuss in 20 minutes, but if you are watching this video, believe me, I see this all the time. We hope our medical students, even American students that are on their fourth year of medicine, they are not ready to have this conversation. They are not ready to understand how to go through the process. And so if you now, with this knowledge I'm giving you, you're able to come to do your observerships, or to do your virtual observerships, or even to get this experience at home, I think it will greatly help your application. And every year we're looking for one student, for one applicant that comes to an interview and has a little extra, a little thing that makes them different. And this is a good one. So guys, good luck with this cycle, and in a couple of days I will come with the next topic in finding your angle.